Welcome, everybody. Thank you so much for joining us today. I'm Nancy Sasaki. I'm the Executive Director at Alliance Healthcare Foundation. We decided we'd go ahead and get started since most of the people have arrived here, and we want to value your time and honor your time and presence here today. So welcome. I just wanted to kind of kick off a little bit and talk about why Alliance Healthcare Foundation is doing this kind of a seminar, workshop, whatever. I don't even know what to call these things. Get up out of here. This is our iEngageU forum where we are trying to present things into the community about the work that we're doing, but also really it's more about the work that they are doing and highlighting that for you, and it kind of gives you a little bit of an idea about what we fund. We realized back in 2010, it seems so long ago, but it really wasn't. But anyway, in 2010, that there are going to be more people in need of the resources and the services that all of y'all are providing, and yet there's not going to be that much more money coming in. The government isn't putting more money out there. Foundations have a little limited resources that they have, philanthropists and other donors in your community. So we're all trying to figure out how do we do more with less, right? Or at least hopefully maintaining even. But we always wanted to try to find those things that are going to lower cost, increase capacity, or improve quality. And that's kind of the three kind of main factors that we look for in most everything that we fund. One of the things that came before us in 2011 was a concept called the community information exchange. When everybody was starting to look at how do we exchange information, how do we really look at what other people are doing with the same person that we're trying to serve. And so we funded the community information exchange, and it's been interesting to see how that's tied into a lot of other community conversations that have been going on. We start talking about what is care coordination? How do we kind of get to that place? How do we even look beyond care being medical care and looking at those kinds of things that are happening outside of the hospital, outside of the clinic? What else is happening to people? Because when you think about it, hopefully the smallest percentage of your time is in the clinic and in the hospital, but there's so much else that you're doing in your life and in your day-to-day stuff that you are doing that affects your health and your wellness, that hopefully keeps you out of the clinic or keeps you out of the hospital. So how do we coordinate all of that so that we know what's happening with that individual person? In fact, recently I was at a workshop that Chip put on that was called Food as Medicine. And we've been doing a lot of work around food systems and learning about what's happening with food systems, and then all of a sudden there's food as medicine. And the hospitals and the clinics are talking about the same thing. How do you have a culinary kitchen where you teach the chefs to provide food that's locally sourced and healthy and nutritious that you're providing to the people that are eating it? I'm like, oh my gosh, we've missed a whole section of the food system. So it's all about how do we figure out that care coordination piece. And then you're starting to hear other topics in the community around whole person care. You're hearing about the accountable communities of health. Or what's the other one, like that? Accountable health communities, or I get them all mixed up, but everybody's trying to figure out, like, now we need to look at this in terms of a community. How are we looking at this? And you see people that are doing, you're going to hear about this anyway, I shouldn't point out people. You're going to hear about some different ways that people are trying to figure out how do we coordinate the care that we're providing to the people that we're providing, because we overlap so many times with the services that we're providing. So what we're going to do today is hopefully hear from we will hear from you three. Hopefully it fits this topic. I'm worried about two of these three. They've been talking, trying to figure out what they're going to talk about today, anyway. But we know that you came here for a particular reason, so we thought that we would capture some of the reasons that you came. What is it that you hope to hear from these three people so they can start thinking about what they're going to talk about? But what is it that you hope to hear from about care coordination and the pros and cons of all of it? Pradeep.
What works and what's not working. And I think the what's not working, if we can be honest and learn from each other to say, we tried that, it didn't work, and here's why, so you don't have to go through that same experience.
So true, right?
And I think I want to hear more about tactics. We recognize the strategies are fabulous, but then what are the tactics that
how do you actually make it work,
Yeah.
right?
Best practices. That's what we hear.
Mm-hmm.
How we can do more to engage the people that are actually being impacted by the things that we're doing to try and improve health in our communities.
engaging with people, sometimes we talk about, self-responsibility. There's so much that we can do and information that we can give, and at some point people have to really adopt it, right, and implement it, put it into practice in their own lives. You don't have the best one. Yeah.
How are people addressing the things that we're learning about the adverse childhood experiences study? How are we looking at trauma? And also the corollary is how are we looking at the relationships that really help individuals?
Right. Anybody on this side of the room?
I'll move.
No, that's fine. You can just, yeah.
I just want to hear more about the resources that are available and how we can collaborate together, not necessarily duplicating services, but maybe we can work together and keep the patients focused so that they're not confused as to, okay, who's calling me and who's this and who's that, so that they're clear. Because I find a lot of times that they're very confused about, because we'll already have those services, but they don't.
Right.
So that's how we can work.
Isn't that the epitome of true care coordination, right?
Exactly.
Making sure that the patient or the client isn't confused about the contacts and the information. Absolutely.
Also just about collaboration, how we're working together to create that community care plan, how we're working with other agencies and what's working, what's not working, but also how to make it work from the top down.
Anybody else? So you guys ready? Y'all know? Y'all have these covered? Y'all have all of that covered? All right. I'm sure they do. I'm sure they do. What we want to start off with is, since you might not know the organizations that are represented here, give them about 5-10 minutes to talk a little bit about your organization and what you do. So we'll just start to my right.
Good morning. It's an honor to be here. My name is Jeff Martin. I am the Executive Director of ElderHelp. I'm just going to briefly tell you how we came to be, talk a little bit about where we are right now and how we are advancing health and wellness, and then just touch on a couple of collaborations. I think as the morning goes on, we'll be able to dive into that a little bit deeper. But ElderHelp was founded in 1973, primarily focused on seniors who are trying to remain independent and in their homes as they navigate the aging process. And we got started because we had a group of inner city ministers and some local business people who persuaded San Diego State University School of Social Work to do a needs assessment in Mid-City, San Diego. And they did that assessment and found that Mid-City, San Diego had a really high concentration of low-income seniors living in their homes, trying to stay there. And so they rallied a group together and created Mid-City Senior Enterprises, which is now ElderHelp. And they believed that even though there were lots of meal programs around, that they wanted to focus on sustaining souls and spirits and socialization and not just what was going into the stomach. Back then, you have to remember in the 70s and 80s, there weren't a whole lot of resources. If you had a family member, you're very lucky to have someone help you as you were aging. Otherwise, there were nursing homes were primarily just your options. And in the 70s and 80s, the beds in nursing homes increased over 30% as the needs started increasing. So they came together and started putting together programs focusing on access to services, independence, access to medical care, transportation, and all of that. They operated out of a basement of a church for 12 years. They had some local government money, and then from there they kind of expanded into ElderHelp as we know today. Today, we have 3 primary programs. We have our Concierge Club, which is a bundle of social services and in-home assessments and anything that we can do to try and help them age safely in their homes and keep their independence. We have our Seniors to Go-Go program, which is a standalone transportation, which oftentimes is the first way that seniors come to us when they've lost their license, which is a huge piece of their independence and access to care. And then we have our Home Share program, which is a shared housing program where we find roommates and match people up with seniors or put seniors in homes that need housing. Those are 3 primary programs. We also handle what we call intake and referral. So about 5,000 calls a year come our way. These are not just 5-minute, come in, give them a number and put them out. These are 5 minutes to 45-minute phone calls where we're doing some real assessment and intake over the phone as best we can to either fit them in our programs or help them find other resources in San Diego County. So that's pretty much just a very brief overview of who we are and what we do. I will say that we pay very close attention as far as advancing health and wellness. We're going in and doing the in-home assessments. We're getting access to medical care. We're helping with health advocacy and literacy. We're creating care plans and care coordination. And we're working with all the other agencies in San Diego to get these services to the people who want to stay in their homes. And of course, it's more affordable. So we are doing that a lot, but we're also paying really close attention to the in-home assessments we're doing and the trends of all the calls that are coming in. So the calls that are coming in, we're paying really closely to what kind of requests are happening over and over again and what kind of services are being needed. And we adjust the services that we have and the programs we have according to that, as I think most agencies do. For example, we were getting a ton of calls from caregivers. We just saw a huge increase in caregiver calls. So we created a corporate education and relations position that's going into local companies and helping with that caregiver piece. Adult caregivers who are working full-time, the loss of productivity is enormous. We created a program to go into companies and help them deal with that. All the research on hospital admissions, ER visits, falls, whatnot. We saw short-term care transition need. We created that position in that program and then reached out to Multicultural Health Foundation and said, how can we support you in your short-term care transition needs? How can our agencies work together? So we're paying very close attention to those needs. We're creating a strategy around that. And then we're identifying partners like Multicultural Health Foundation, like 211, like Meals on Wheels, and saying, let's sit in a room together and figure out how we can tackle these problems. And I will say, especially looking at fall reduction and the cost of care in San Diego, we know that the average cost of care for a fall and a hospitalization is $35,000. We know that according to Health and Human Services Agency's own assessment in San Diego County, that more than 50% of seniors being hospitalized were due to preventable. They were preventable hospitalization, and Medicare is paying 78% of that. So we are perfectly positioned to be preventive and proactive in delivering services that are going to reduce the cost, and then find partners like these handsome gentlemen to my right who can help us facilitate that much better to the community at large. That's kind of an overview, and I know we'll get deeper into the collaborative part a little bit later.
Good morning. My name is Dr. Rodney Good. I'm a physician here in San Diego. Been practicing here in San Diego for about 4 years. I'm only about 55. So I've been here a long time. And I am the president of Multicultural Health Foundation, which actually received its 501c3 in 2012. So we're a very young entity. Before I get off into the technical aspects of kind of what we do, most of the folks associated with the foundation consider themselves revolutionary. We really are talking about doing things that thinking outside of the box. Now, what I found when you ask somebody, I want you to think outside of the box, what they come up with is a new idea within the box. and because if you truly come up with an idea outside of the box, 9% of the people start telling you why it won't work. And so the concept of the Multicultural Health Foundation was really based upon developing health equity within San Diego. And what I mean by health equity, when we look at any county, let's start in San Diego, there are differences in health outcomes depending upon where you live and what your ethnicity is. Okay? Your life expectancy and the area where I practice is about 74, 75, 76 years. Up in La Jolla, it's 85. Why? There's lots of factors that go up into that. How do we actually talk about health equity and do something about it? And I learned some time ago what I call about the medical holy trinity. It's called medicine, politics, and money. And it's the latter two that control what we do in medicine. And so, as Nancy said, there's plenty of money in the system. But to me, it's not all being directed in the same place. And so I'm going to tell my little secret. The foundation is trying to figure out how do we take money that's already in the system and direct it to a entity that's dedicated to building an infrastructure within the community. About 4 years ago, I'm also president of another entity called the Multicultural Medical Group. It's an independent physician group of docs like myself who have been practicing in San Diego. There's about 130 primary care docs, 200 plus specialty docs that are part of this IPA. Many of us take care of the same type of population that the clinics take care of. We see Medicaid, seniors, and commercial. We were approached about 3.5 years ago to be part of a national grant. It was called a CMMI Innovation Grant, in which part of Obamacare, they gave about $3 million to this new center. And they wanted people to come up with new ideas, thinking outside of the box about improving outcomes, improving quality, and CMS really about saving money. That was the real interest. And we were part of a hotspotting grant. Started in Camden, New Jersey with Jeffrey Brenner. And then there were 4 other sites identified to see if we could replicate what they were doing in Camden, New Jersey, where they would pick the sickest patients, do local intervention, try and do what we call keep them home, healthy, and safe. And then document were there any savings. The grant ended about a year ago. And it was through, we were the only IPA for-profit that was part of this national grant. But we realized a lot of what we were doing, 70% of what we were doing wasn't clinical integration, clinical navigation, but social. Because a lot of the patients that were using the hospital and ER a lot were mainly because they had difficulty overcoming the social barriers. So we put together a team of nurses, social workers, navigators, community health workers, and these are folks from the community, created what I call a virtual patient-centered medical home, where we weren't just limited by geography. We were dealing with multiple doctors' offices and said, give us your sickest and most difficult patients to control, and put together an intervention strategy where we would do home visits. This program was called the Patient Health Improvement Initiative. And at the end of 3 years, we had significant success. We transferred the grant from the IPA to the foundation because we realized that in order to become sustainable, a lot of what we were doing was overcoming social barriers. But the healthcare industry doesn't pay for overcoming social barriers. You got to beg for money. So you have to go to the Alliance Healthcare Foundation. You have to go to the endowment. Our philosophy was we don't like begging. So we believe with developing a model in a foundation where maybe 80 and 90% of the income is coming from foundation grants. But sustainability means that should be reversed. That in 5-10 years, most of our money should be coming from a business model that's contracting with other entities that are used to just contracting with physicians to help keep the patients home healthy and safe. And we were able to show at the end of 3 years, with a small subset of patients, about 600 patients, we were able to save $9.8 million to the health system here in San Diego. And when we looked at, even after we stopped the intervention, a year later, there was still a significant savings as compared to before, equaling about $16.5 million. The interesting thing is the foundation really received none of that savings. So the savings were really at the health plan level and at the health system level. So our strategy is to say, contract with us. We were able to convince 4 entities today to contract with the Multicultural Health Foundation to keep our intervention team intact. And And the culture of the foundation is our charge is a certain percentage of that will go to build a wellness fund. And that wellness fund, as it grows, will be used to build the infrastructure in the home and in the community that we think is needed to kind of keep folks out of the hospital. We also believe that we're not going to be successful unless we're involved in community engagement. So you've heard about, there are 3 pillars. One is the business model, patient health improvement initiative. That's focusing on the service. And by doing intervention there, you save the most money. Those savings then go to a wellness reinvestment strategy to hire more community caseworkers to continue to work with these patients. And then the third strategy is what we call HEAP, Health, Equity, Action, Think Tank. So people have think tanks, but we believe it should be a community-based. And we don't believe in just thinking, we believe in action. So that's why we put the word action in there. And basically, what we do is try to educate the community about the issues of the social barriers. So we have put together several community forums, one in which we had 500-600 folks attend, talking about, we had the president of the American Public Health Association, Dr. Kamara Jones, who talks about how does race and racism intersect with the public health system and how does that affect outcomes. People are still asking for her to come back. So there's a lot of community engagement forums. Somebody mentioned about ACEs and trauma and violence. I don't ask me how, but just became chair of the gang commission here in San Diego. And what I learned is violence isn't just violence. It starts early with adverse childhood experiences, with experiences at home, and how do you deal with that? Because all of these lead to chronic diseases. So the other is, in order for the Multicultural Health Foundation to be successful, you need collaboration. But above and beyond that, you need integration. One of the first things we did was tour 211. And John's services saying, we need help with referrals and resources. And you'll hear later, we're now talking about partnering with ElderHelp to expand our patient health improvement initiative to kind of not just collaborate, but integrate. Thank you.
Good job.
And looking back, are we still on the web, World Wide Web?
Yes, we are.
Everyone want to say hi?
We're there.
You guys can run and say hi to everyone.
It just went away.
Oh.
I don't know.
Yeah, we have people with us virtually right now.
Oh, there it is. All right, turn around, say hi. Well, welcome to the Connection Center also. So our quick history, it's kind of interesting. We actually came out of the United Way about 30, 40 years ago when the United Way was giving a lot of money to different community-based organizations. They actually knew who those organizations were in town and created a directory at one point in time because people would call the United Way and say, I'm looking for this type of provider. Can I get the information? And little by little, it grew into a department of the United Way called InfoLine. InfoLine became a 10-digit number that people could call in. Agencies would call in and say, I need the closest food bank or I need the closest senior service provider. And over time, InfoLine produced a directions catalog. Anyone remember the directions catalog? Anyone use it here? Anyone miss it? So, and then about 11, 12 years ago, we actually went for the 201 dialing code, which was set up by the FCC to be a community health. And then later on, they realized that disaster would be a part of it as well. And because we had this formation of this organization, at that time, about 15 years ago, United Way departed with 211. So 211 and the Volunteer Center became their own standalone, Volunteer San Diego, became standalone organizations. And at that time, then we adopted the 201 dialing code, moved from InfoLine, and now you have 201 San Diego. And so over the years, we went from answering something like 60 calls a day the time that I was coming on board. Obviously, during disasters, we'll receive tens of thousands of calls in a day. And what we're averaging now is about 40,000 calls a month. And if you add to that about 45,000 people that are visiting our website each month as well, because a lot of the information we give out is not only through our phone-based agents, it's through online searches. Our entire directions catalog was virtualized and put online. And there's some focus pages and things like that. So if you think about it, we almost have 1 million people coming to us every year for information. What we found out was about 60% of those visitors that are calling in are repeats. They've used our services before. Maybe they called for something, got a service, and then a few months later needed additional services. In some cases, it's not as great. We have people that we might hear from 17 times in a month because they call us and we give them information, and they might reach out to that agency and find out either that agency doesn't provide that exact service, or they don't qualify, or they live in the wrong zip code. They'll call us back. Some of our most hostile callers are actually people that we made hostile by answering the call, trying to give them the best information, wishing them luck, and hearing back from them. And it was funny because last week, Bill York, who's my business partner in this, actually went to lunch with a veteran spouse who called us and actually had a really difficult experience, expressed her view, and then they went to lunch and actually were brainstorming about what's going on, because how else are we going to know if our service is working if we're not hearing from our clients? And so a while back, I think it was now, do we go for the I2? 4 years ago? 5? 2012. 2012? Is that 4 years ago? So 4 years ago, when Alliance Healthcare Foundation was having their innovation grant, it was all about come up with a new idea, a way that maybe you could help, obviously, lower costs, which if you think of repeat calls to 211 and also repeat calls to agencies and that maze of confusion, there's cost. Improve health, like Dr. Hood just said. So many of the issues that people are calling about are social services needs that escalate and then become chronic health situations, and improve the system. And so our concept was, wouldn't it be great if when 211 spent 7 to 10 minutes on the phone with each client, which we do to do a full assessment of what's going on, what's the underlying cause. No, they don't just need a phone number, maybe they need health insurance, so we can help them apply through our benefits and enrollment department, or Medi-Cal, Covered California, CalFresh, food stamps, and other types of services. Maybe they qualify for a discount on their utility bill. Maybe there's a service that's close by to them that they can access. We're getting all this information, and then we're giving them a phone number and saying, good luck. Wouldn't it be great if that information could be passed on to the community-based organization? So San Ysidro Health Center could actually say, hey, you know what, we're making a referral to you. Oh, and by the way, let's book them an appointment. And by the way, here's their social service record that we've collected information, so you don't have to start from the beginning. And by the way, when you see that client and fill some of those social service needs, what if we had a closed loop referral coming back? So that when that person calls back, not only do we know what their experience was, how they were helped, maybe also what else they need. Because when I look around the room, I see so many partners that are already working together, and we're sending people to you, but we're not all coordinating. And so more and more we feel this need to have a coordination tool. So that grant we won was called the Community Information Exchange. So raise your hand if you haven't heard of the Community Information Exchange. Great. They're good. Okay. So it was that concept, to build a social service information exchange, to build a way that all of the partners that serve clients can see a client record at a point in time to help all of you serve that client better, help us coordinate, because more and more with 100,000 of our San Diegans calling us each month, imagine how much better we could be serving all of you if we had a little bit more information, if we knew what their stories were. And so the concept was born. We had a number of partners. We started some cohorts. Our first cohort, which was really focused on taking Project 25 to scale, which now there's about 6,000 people in that repository for cohort 1, involved partners like St. Vincent de Paul, PATH, Alpha Project, Scripps, yes, I'm reading too much Scripps, Fire Rescue, EMS. And what they found during the first year evaluation was there was a 26% reduction in EMS transports, pre and post, of clients that were actually looked up in the exchange by social service providers. We had a 38% decrease in people moving from permanent housing to the streets because for some reason something was going on, right, and they end up losing their housing. We had a 38% reduction of people losing their housing. And we had a 44% increase in people remaining in housing. And so that's just in 1 year with 6,000 clients, with basically only a few partners working together. And so we then, CIE then started a second cohort, which was focused on seniors. So you'll, obviously, I think we'll talk a little bit more about that in a little bit, because there's a number of other projects. But if you think about that same kind of coordination, right, that any one of these service providers, whether it's ElderHelp, Meals on Wheels, Family Health Centers, serving seniors at UCSD, has a client, they pull up the lookup on the CIE to see, has this client been helped? Who else is working with this client? Maybe I need to pick up the phone and talk to the other caseworker. Lots of coordination that's happening. And we haven't done evaluation yet. At the end of the year, we'll evaluate it. But more and more, we were getting to the place of looking at CIE and what it had been doing, the great success. But with only 6,000 people in that repository, if we think about all the clients we serve together and we unduplicate it, I would guess there's probably 100 to 200,000 people. So how do we get it to scale? How do we get the repository of CIE to have all of your clients, all of Deb's clients, all of my clients, all of your clients, so that we can see a full coordination and a full person record? And so we, CIE had been on its own, and as of February, we reacquired it to 211, because we were having that same feeling at 211 is we need to keep a client record as well. So it's important for us to keep it, but it's more important for us to share it among the providers. And so we now have a bold project. We're investing millions of dollars into technology. We're in part of Alliance Foundation's Invest Up strategy. We've also received funding. I know Dr. Nora is here from Molina Healthcare as well, and Kristen Garrett's here, in terms of how do we get this to scale. And so I think what we're trying to do is get enough people involved to know, you know, people said there's a lot of duplication in the system. There's a lot of money being spent. I'm a firm believer the same way that the money is there. It's just if we can improve the coordination, we're going to see great success. So we're very excited about that. I'm looking over at Jessica here. Okay, good. So I'll stop at that and see if there's questions. I do better with that.
Well, I think, you know, what's really interesting about this is now you've heard kind of the silo of what each of these organizations is doing. But what we really wanted to get into now was, so how are y'all getting out of your silos and starting to work together, trying to answer some of these other questions that are there? Like, what are the tactics? What's really happening? How are you actually making that happen? Or what's the dream of making that happen? And what have you already found so far that's working? And where are the stumbling blocks? What are you finding that is really some of the barriers to making this happen? It's a dream. Well, I see all of y'all nodding your heads when you're talking, when they start talking about care coordination. And wouldn't it be great if we could share this? And everybody's like, oh yeah, oh yeah, oh yeah. What keeps us from getting there? What are you guys seeing so far in the work that you're doing? So this is where you stop talking about your individual organizations, or actually some of it might be about your individual organizations and the systems or the processes or the policies or whatever it might be that's keeping you from being able to truly be able to share across the board with each other. So
I'll jump in. When I came on board, my predecessor, I feel like, already set up that standard. 211 was actually created because there was a coalition of, Kristen, how many organizations? Hundreds of organizations that came together and said, we need a 211. We need a central access point. So that coalition and steering committee, while those that one steering committee is not in existence anymore, a number of those people are involved in different groups that are working on health, working on veterans issues, coming together and saying, what do all our providers need so that when that veteran calls 211, how are we going to work together? Because we don't know. We're not the experts in your field, but we're receiving the calls. So we have to collaborate to build our product to be effective. So I think it's part of our DNA just to always bring in people and say, what should we be doing? We're noticing this. What can we be doing? We need kind of a client.
Well, for us, I would just say I'm a huge fan of collaboration and integration. I think that it was always eye-opening to go to the USC State of the Nonprofit Union and hear that there's more than 10,000 nonprofits, and 75% of them have revenues of less than $50,000. So there's a huge amount of duplication and overlap, reinventing the wheel going on. And for us, our first thing was there's just not enough resources for everyone. And how can we more efficiently reach more people who need our services and do it more effectively? and more efficiently. And so the first thing we're going to do is identify what our needs are, and then who else is in the community in that space. Or maybe it's not obvious initially that they're in that space, but there's got to be some way to bring that together and synergize that. For example, a third of our calls come from 211, and we thought it was important to have proximity to them and see how we can be a part of the collaborations that they're building, collaborations we want to build. And it was actually, I looked it up over a year plus, November 2014, when I had heard that 211 was looking for space, and I emailed John. And I said, what are you going to do with the space? And is there room for us? Let's talk about what that looks like. And while we were waiting to see what that looked like, Teresa Stivers and I with Baldwin Family Services went out and started looking for space. Because I thought it was so important to be with other nonprofits and have a synergy and get outside of ourselves. And it didn't have to be a senior agency. It just had to be a nonprofit to share ideas, and share information, and share resources, and share space, see what we could generate from that. Same with the Multicultural Health Foundation. As Dr. Hood has talked about, and Montrula is here. We have these amazing care coordinators, and they spend a great deal of time, and they're truly social workers, and they're having high volumes of calls, and they're really good at it. They're basically all trained in some kind of gerontology or something around that. And it's hard to get people to pay for that because you don't always see it. You don't always see it being put to work. You know, you see the volunteers out in the field, you see me, you see people out there. But the care coordination is kind of a silent support system that can be hard for people to understand how to pay for that, especially the people utilizing it, users. So here we have this great care coordination, and Multicultural Health Foundation was doing a lot of the same work, but at a higher clinical level. They were taking these amazing clinical staff, and they were spending their time doing things that maybe weren't their highest and best use and the most affordable use. We have these care coordinators who are really good at that lower level social work, intervention, care coordination in the home. How can we supplement your staff with our staff so that you're not using these highly clinical people to do things that we can do much more efficiently and affordably? Let's see what that looks like. It takes a year. It takes a year. To lay the groundwork, to create the relationship and understand each other's model and the culture. So there's a lot of talk about collaboration, which I'm a huge fan of. But real collaboration is integration, which is messy, and it's a lot of work, and it's painful, very painful. It's learning each other's cultures and then trying to get those cultures to fit. It's making sure that your mission, vision, and values are the same, and that at the end of the day, it's getting all the egos out of the way and saying, is this going to help more people? And is this the best way to do it and the most efficient way to do that? And only then can you truly bring people to the table and start having conversations about that. So we have another partnership with Meals on Wheels and Great Call that we recently came together and said, you have 2,000 volunteers delivering meals to isolated seniors. Your seniors need our care coordination. Our seniors may need your boots on the ground going in and finding these people. And let's throw in a technology piece with Great Call and see, create a dashboard so that all of us together, we're care coordinating your volunteers, your drivers, and these dashboard monitoring and bringing this all around in a wraparound service to be preventive and proactive. So, you know, a lot of it's just really identifying what that is and then getting in that room and being prepared for the year-long or more process to really start creating the integration and the time that it takes to do that.
Can you take it down even to the next level of, so you both have care coordinators on each of your staff between Multicultural and yourself or Meals on Wheels or whatever. How are you making that determination of which care coordinator is working with that patient? I mean, there's obviously a warm handoff at some point, but how does that communication between you two work? Is there a specific contract that outlines that? Can you give a little more detail?
I can, and I'll let Dr. Hood and Montrula. So we are almost finalizing a contract that spells out specifically their role, our role, the metrics that we're looking at, the transition of care from their staff to our staff. We've had countless meetings with parts of our team and all of our team, conference calls, and then Multicultural Health Foundation. I think we're all very good communicators, which helps a lot. We're having weekly team meetings, care coordination team meetings with their team and our team. Also, even before we got to the contract stage, and all of these meetings, we wanted to shatter. So we have a short-term care coordinator. She's in the room actually, so I won't embarrass her. But she's terrific. She started working with Dr. Hood and their team, shadowing and going out into the home and looking at their level of critical care. These are really high utilizers of the system. They're low income. They have far more chronic issues than a lot of our standard population does that we deal with. We really wanted to see, what does your patient look like? What's the average snapshot of that? Are we the right fit for that? And how will we change our care coordination to better serve this particular population? I'll let Dr. Hood address the rest of that.
So the answer to what you're asking is we're still working this out. It's hard work. And I didn't realize how many not-for-profits. So I come from the for-profit world, new to the not-for-profit world. And to be honest with you, there really isn't much difference in the cultures, in my humble opinion. The competitiveness amongst the not-for-profits. And so navigating that, how do you convince the issue is I truly believe that we have to merge the two. Okay? Because there are some synergies, whether you're for-profit or not-for-profit, that with the synergy comes. How do you change the culture of the for-profit where the whole issue is the bottom line versus the not-for-profit where the whole issue is how can I continue my program? And what we're finding out is you got to look for the synergistic values. So putting the foundation together, I had to have my IPA, which is for-profit, to find a value in supporting the not-for-profit. And they did because they could see that their patients were benefiting. It was keeping them out of the hospital. They were saving money, and therefore they could share some of that saving with the for-profit. In order to do this, we needed partnerships. And one of the things we've learned, first of all, let me tell you what our team does. It's a small team of 2 nurses, 2 social workers, medical director, a program strategist, and administrative help. And we identify, anybody have an idea as to 1% of the population in the health system accounts for what percent of the cost? $3 trillion. 1% accounts, we spend $3 trillion in healthcare. 1% accounts for 21, 22% of that. Just 1% of the population. 5% of the population accounts for what? 50%. So 95% is utilizing half of the cost, and 5% is using the other half. So we focus on numbers. Well, how many did you serve? So although we served a small number, we saved the most money. You would have had to encounter 20,000 of the 95% to save the same amount of the 200 of the 1%. The question is, by focusing on that, you can save more money, but it's what you do with that savings. And what we learned over the 3 years was that in order to expand the program, we could either do it internally or look for partners that were already doing similar work, and sometimes even doing it better than us. And so we've been talking with ElderHelp, learned that they have a very good program, especially their volunteer program. We found the volunteers in our program very helpful. And we just don't want a collaboration between the Multicultural Health Foundation and ElderHelp. We're trying to integrate a community caseworker, Nicole, excellent, into our patient health improvement team. Each patient gets a home visit. It's not a 10, 15 minute visit. It's a 2 to 3 hour visit, okay, where the social worker goes, the clinical person goes, and we're trying to get a mental health worker working with mental health organization to kind of supply a mental health worker, because 80% of what we see has mental health going on. And that was probably one of our weaknesses. And based upon that, developing a clinical goals and intervention and social goals and intervention. And what we found is 70% of what we were doing was social. As a provider, one of the first patients that was enrolled in this program was a patient of mine I've been following for 12 years, she told me. She had been in and out of the hospital 6 times over the 6 months prior to the intervention. She had one of the best primary care doctors in town. I could not keep her out of the ER. So, you know, we go back to going to the ER, it's a matter of access. They can't get in to see you. I was seeing her all the time. Nice lady. She'd come in with a powerful of medications. I spent 20, 30 minutes going through her medications. A month later, she's back in the hospital. She enrolls in the program. She gets to meet Montrula, Alicia. They visited her at home. I learned more about that patient in 3 months than I knew in 12 years. Over the next year, she went to the hospital once. She had financial issues, social issues, food issues, transportation issues, and accessing some of the resources through 211, the hard work of the team. The benefit to me, she wasn't calling my office all the time, she was calling them. I love that. And I learned as a physician, it's teamwork, okay? It is not really about the physician. It's really about the team and kind of what they're doing. But I think it's important to kind of coordinate that care with the team. And then if, in my humble opinion, if collaboration doesn't lead to integration, it's not going to work. And so that's breaking down the silos. I come from the private doc entity that takes care of some of the same patients as the federally qualified clinics. There's always been this stuff going on between federally qualified clinics and private docs. We're trying to break that down. We're now working with some of the clinics. Many of the patients that went through the Patient Health Improvement Program were federally qualified health clinic patients. They were Kaiser patients. So the other thing we're doing is trying to do something that's agnostic, not just build up a system based upon one health system, but patients are migrating from Scripps to Shaw's to Kaiser to the clinics into the private docs all the time. And when they do, they fall through the cracks. When they get in our program, it doesn't make any difference what system they're in. We continue to follow.
Is it okay to ask a question?
Sure, absolutely.
Do you have another, we love the metric of fewer hospitalizations or rehospitalizations and fewer ER visits, but do you use any other metric to reflect your success?
Excellent question. Yeah, the patient. So one is at the end, and we had about a 90-95% patient satisfaction. We decreased hospitalizations by about 22%. We decreased ER utilizations by 30+%. And the patients' well-being improved. They, many of them got more engaged back into the community. We are only now beginning to look at outcomes. So hypertension, diabetes. I can't give you the data because we haven't really got that data, but where we were focused on utilization and financial data, that was really the purpose of the grants. And now we're beginning to retrospectively start looking at the diagnoses and outcomes. So we won't know that, I think, for a while.
What's some of the others, Jeff, and John, the metrics that you're using to?
Well, it was interesting because it kind of ties into the question of tactics to make it work or what's not working is, so I'll back up for a second and then go into that, is technology. I think when people hear that we need to share information or we need to work together, I think everyone always kind of goes back to the place of, well, we all have to use the same system. And that's not the truth. It's not what's needed. all of us can work together in individual technology solutions that work for our individual interests, but the sharing of social service information can happen with, CIE works with multiple tools, and as we continue to develop it, it's not going to be to force any tool onto an organization. You already have something that works for you. And based on that, think about the measurement side is we're looking at, are we calling it a care plan? Is that what we're calling the report, the risk rating scale? And it's in development, and really what it looks like is, I always say, picture pulling up a client record and seeing the social determinants of health laid out there. What's their housing situation, what's their food situation, where's their, do they have a medical home? And picture a red, green, or yellow dashboard. And it could show you, red where, hey, this case manager has been looking for this person to fill out this form so that they can actually get their CalFresh benefits. Or a yellow is we haven't heard from them in a while, but we're hoping that they're still in their housing provider. Or a green is, if we started using a similar language among ours, again, you don't have to use the same technology, but if we can have similar dashboards, the data that you're contributing, the data that we're contributing, will allow for better outcome data, shared outcome data. I think one of the things that you mentioned in terms of the political support, I always picture one of our clients calling in and having a frustrating experience with an agency, and not picking on anyone in the room, but we know that happens, right? So there's organizations in town or there's resources that are just not available in certain zip codes. But that one person can call us back and be frustrated, and then that's a phone call. But if we could take 5,000 of those voices, if we could take 2,000, if we can go to our local electeds with dashboards, mapping and showing the gaps in services, the gaps in needs in certain zip codes, because together we're all reporting it, it's hard for them to look the other way. And then when we push for certain advocacy efforts to happen in terms of shifting funding streams, creating funding streams, better coordination, we now have the data to report on it. 201 alone can't report on the unmet needs in the community. Neither can, I think, any one of us individually. And so that's something that I'm not sure.
Thank you. So go ahead.
Oh, just a quick question for you, John. That community information exchange sounds like a great means to furthering what we're in the room to discuss today. What does it take to become a part of that, and what are the biggest barriers you see?
So
for an individual organization wanting to get on board with that.
Sure. So the two cohorts that are in existence, if you're working with senior clients, we're looking for participants to add to the cohort. Obviously, the downtown homeless was really what cohort 1 was about. Now we're looking to scale. And so what we're looking to do is put together advisory groups depending on what area you serve, whether it's a geographic area or, we work with veterans, because we're going to be planning more and more pilots. And they're not even pilots at that point. It's really focusing on certain geographic or client demographics that are there. So please follow up with me right after this.
Okay, cool. Thanks.
And I guess the greatest challenge is getting, just like everyone said, it's everyone taking egos out of the way and saying this actually will make sense. I think as we have more scale and there's more clients, so that when you ping the CIE to see if a client has information in the exchange, the more that you have information coming back to you, the more willing you probably are to contribute to it as well.
So, John, staying with that point, what's the ability to share information? Everyone tends to work in silos because they know their clientele best, cultural sensitivities. The HIPAA consent and financial disclosure consent, has there been an effort to standardize enrollment applications? So
our legal team's in the back. No, seriously, she is. Shelley Wade, and
I'm gonna go out the door here.
Shelley's also, we brought her on board because she's been working as the legal advisor for the health information exchange. We have San Diego Health Connect, which is linking together docs and hospitals and labs, and that's where the health information resides. And it's a little different because it's not a repository. So the information is not stored in Health Connect, but it's shared among providers. What we're doing with the Community Information Exchange is actually building a repository, because one of the benefits of having all that data in one spot, that doesn't mean it doesn't sit at the agency as well, is you're going to be able to see a bigger picture, and you're also going to be able to do outcome measurements and evaluation work on it. So we're obviously working on not only legal privacy and consent. So if a client says, yeah, John, you can share my information with ElderHelp. Well, are they also saying that if another organization decides to work with us, that we can share information there as well? And what are the governance standards that we're going to have with the providers signing up saying so all of that is being worked on. It's been piloted with cohort 1 and 2. I think the distinction that we need to be really careful with is that this is not healthcare information, and where we can draw the line, because the healthcare information hopefully is being shared with San Diego Health Connect, but there are times when we're going to be really close to so we're following HIPAA even though we're dealing with mostly social service information.
Well, healthcare information and wellness information.
Right.
I guess social needs, financial needs.
It's all related, and so it's hard to draw that line and say, oh, we're not going to share that when you have provider to provider working together. And so those are some of the things that we need to work.
Would there be some economies of having each organization, when they enroll their own clients, have that enrollment share the information with certain participants?
Yeah, and the hope is that consent would be not only when 2-on-1 consents someone in the CIE, but any one of our providers have a consistent consent.
Now, that's one of the areas that I think we're starting to see where policies and guidelines are colliding with the whole concept of whole person care, with the accountable care communities and that kind of thing, and that there are policies like HIPAA that don't allow you to share information, and yet how can you have whole person care and whole person care coordination if you can't share information? So you're starting to see where those collisions are happening, and there's a lot of work I think that other people are doing to try and break down those, or even for especially the nonprofit social sector, to become more HIPAA compliant, because it enables them to be a participant in all of that. Right. You're starting to see some of that. Yeah.
So John, are you saying, so if you opt in at any point in the system, the patient provides consent at any point, and any of your providers, you all have BAAs, there's only one opt-in consent necessary. Is that what you're saying?
Correct. Okay. For the CIE as it currently stands. Because there's just 6 providers right now.
Right now, but in the future.
Yes, that would be the goal.
Okay.
Yeah, right.
So you know that there are, I heard somebody in the audience say we want integration top down. Really, I totally understand that because I've worked at the top for a while. But it really needs to take place from the bottom up. And in some place we're going to meet. And probably one of the most difficult, I mentioned the CMMI grant. Probably the first year of the CMMI grant, we were negotiating HIPAA contractual arrangements with the health systems to share data, especially financial data. And it was the most difficult process because every health system has their own legal team and has their own interpretation of kind of what's needed. And I'm not really sure the issue is more HIPAA than it is how folks want to interpret what HIPAA means. And sometimes systems hide behind their institutional standards. That's just my humble opinion. So we need integration of the not-for-profits and for-profits down at the community level, but also at the macro level with the health systems and the health systems who are willing to kind of share information, because when we talk with various health plans about what we're doing, the health plans and health systems are all doing the same thing. As a matter of fact, in their mind, we're already doing what you're doing. Okay? So everybody thinks they're already doing the clinical integration. And on paper, it looks like they are. But that's why I go back to the 1%. Whatever system you have designed for your system may be effective in 80%. But the most costly ones, especially in the populations that we deal with, need to have a culturally appropriate intervention strategy. And that's where I think the bottom-up comes. And at some point in time, when I'm looking at it as they're integrating up here, like the health systems need to come together to say, here's one form and one way we can coordinate. And I think we're getting there, but we're not there.
What's interesting is I've been making some notes about the kinds of things that I'm hearing, and some things that I'm hearing, they have been glossing over a little bit as being something that's really easy. The first thing that I wrote down is that as leaders of their organizations, they created a culture of collaboration. They came at it as already being that open mind, saying, we need to see what else is out there. We need to see what other people are doing. We need to assess our own strengths and find out what else we need to add to this. And we don't need to necessarily create that resource within our organization, because with 10,196 nonprofits out there, there's somebody doing it. And we need to be able to look and see who else is out there. Being that kind of open mind, creating that kind of culture within your organization, I think is really, really critical before you can even start talking about how you coordinate care, how you collaborate. I think that that's something that, you know, when you have it, you have it. And you just assume that everybody else does, or you think that it comes so naturally. And yet probably all of us know that leader that really thinks that what they're doing is the best way and the only way, and everybody else should get on board with me, right? And so, you know, that's one of the first things that if you want to talk about collaboration and really this integration, you know, you've got to be able to find those people that are leaders with that kind of an open mind. I also talked about, you know, there was a question up there about what are the actual tactics, and so much of that had to do with how do you really begin to get into the details and the nitty-gritty. And so many times nonprofits see a need, they want to solve it now, they want to address it now. They talked about a year minimum to get through some of those details about what are our cultures, how would we work together, what is the work that you do. I don't want to just assume that I know what you do, I'm going to shadow you. I mean, really? How many of you have ever thought about doing that? You know, like, I'm just going to send a staff person to go watch what you do, to get a sense about it, and to understand what you're doing, to understand how cultures might collide and where there might be those kinds of tensions that we have to work through, that we have to change our procedures in order to fit your procedures. You know, that kind of stuff. Again, these are not things that just come naturally, but if you're going to get into this work, if you're the person that's sitting here, y'all all came to this because you're interested in how this coordination is happening, how this collaboration is happening, so you've got it. But just remember that people out there in the community that you're going to want to work with might not have it, and you're going to need to do some of that work to get them to that place where they can have that kind of an open mind. Then if they can let go of egos, you can find the synergies, you can understand each other. I mean, these are not easy things to do, right? Then you can decide, like, okay, what are we going to measure? How are we going to know what we're doing is successful? And it was interesting to also hear that initially there are some things that you might want to work on, even if they're the first baby step to your real ultimate goals. In foundations, we talk a lot about how we want to not just see the numbers that are coming in the door. We want to know what happens to that person when they walk out your door. How are their lives better in terms of their health and wellness, which is, of course, our focus. How are their lives better? And so we're watching organizations kind of get to that as they go through the phases. Now we can start seeing, are we actually reducing the amount of chronic disease? Are we reducing the number of heart attacks? Are we decreasing weight? All of these kinds of things that ultimately rely on, back to coming to the circle, self-responsibility and that individual really engaging. So all of y'all have talked about the work that you're doing. One of the questions that was up there, how are you engaging the people in this work? How do you get them to let you into their house and talk with you? How do you let them talk? How do you get them to let you talk to their children? How do you get them to talk about their food? How do you engage people?
Well, that's a loaded question for us. We're dealing with isolated seniors, and as a rule, there's not always a high level of trust to have someone come in your home. And so the first thing, of course, is building the trust and relationship over the phone, and getting them to understand that we're not going to come in, and fortunately, we're not a government agency, so we're not going to, usually even if their home is in a very difficult shape, and their health is not good, and their support systems aren't good, leaving them at home is probably still by far the best alternative for us to treat them and provide services. So oftentimes our staff are so good at developing that relationship over the phone till they get to the point where just let us come in and see what's going on there and see how we can help you, what resources we can provide, and who are you relying on right now for your care and support. But it is a process to do that. And to Dr. Hood's point, when we're in the home, we're there 2 and 3 hours, and then from that point on, we're a part of that relationship for as long as she'll stay in one of our programs. And we're lucky that we handle, like I said, about 5,000 calls, which may not seem like a lot to other agencies, but again, there's a significant amount of time being spent on these calls. And Nancy mentioned something earlier. One of the things I think that we're very, it's important to us is we're not trying to be all things to all people. We know what we're good at, and that's what we want to stay in. If there's a gap in service that we can fill, we will. If not, we're going to find the partner. So part of it is that our numbers aren't huge, but our impact is huge. And we know that we're not just churning out these calls, but we're truly making some significant social changes that are happening on those calls and going into the home. I don't know. It's a hard question to answer from our point because you're talking engagement on many levels. The senior, the support system around that senior, which for us is oftentimes completely non-existent, no family, no nothing. And then the volunteer engagement, the community engagement, which in San Diego, community engagement in senior agencies is very small. Foundation support is very small. We're very fortunate Alliance Healthcare is in that space because I shudder to think what would happen to some of the agencies that focus on seniors without their support. Engaging local corporations, again, seniors aren't sexy things for people to spend money on and to support, even though it affects all of us. And I guarantee you that everyone in this room is either taking care of someone or worried about someone or will be taking care of someone. I get calls every day, and it's amazing. I get stopped in the shopping, in the line at the market when they find out what I do. But still getting that kind of engagement from the person, from the volunteers, from the community is a nonstop battle. And I know I was all over the place with that. But I don't know if that entirely answers the question, but the engagement piece is just patience and time and steps. It's the turtle. It's just moving forward and not being discouraged. Same with any collaboration. We deal with our seniors and their families the same way. We're not going to give up on them. We know oftentimes by the time they come to us, it's a last resort. And it's our duty to try and find a way to honor their dignity and their aging choices. Not to mention that even if you don't want to focus on the senior aspect of it, it's really good business. It is affordable. It is reducing health care. We know we reduce costs. We've had same studies. Our value saved is $5 million a year in the reduction of health care costs. So we know what we're doing. And it's a human dignity issue. I think that they're entitled to these choices, and we are in a position to do that with the right partners who can help us scale. That's a little bit of our engagement, but not a specific strategy per se, just the nature of what we do.
So I just wanted to say something. I initiate those calls, that it is a challenge sometimes, but because when I initially call them, I tell them that I'm a registered nurse. That opens the door, just because they know that there's a professional person on the phone. And then I let them know our process and who we're there and who referred them. And they're very receptive when you tell them that their doctor has referred them along with their health plan, felt that they were a very good candidate for this program that is free to you. So when I say those initial things, that engages them, because you have to break the ice. Because people really, a lot of different cultures and all that, they don't really want people in their homes. But once they let us in, then they don't want us to leave. That's the thing, that we just become a part of the family. And one patient right now that I'm the only contact person for her, because she has no family. And she has 2 nieces that live on the East Coast. So, and she right now is custodial at a facility. And so, if anything goes wrong, they call me. It's just that there is no one else that she has. So, and she's one that said that your agency is a godsend. You're a godsend to us. So it's establishing the relationship. Another thing I want to say is I keep hearing over and over is about the ego. We can break those down and work together. It makes all the difference, because what I always say and what actually happens in our program is that we make a difference in these patients' lives every day. And knowing that we're there, as a resource for them, that is very, very effective. Very effective. And if everyone could work together in making that happen and not say we know for the benefits of COP. It's not about that. It's about what is our true purpose, and are we able to fulfill that by working together?
Montrulo brings up a great point about community, about that engagement, and that's the word free.
Right.
Well, say, we used to have a membership fee model, and it was a huge barrier to reaching the population we deal with. Obviously, you know, they're already low incomes. So they don't get the value. They want to understand, what am I paying for, and why am I paying for it, and is there an upfront fee, and is there a monthly? And we tried that model for 8 years, and I just found it was a tremendous barrier to actually getting the services out there. It's better to, there's no quid pro quo. You know, we just want to get in your home, and we want to help you. Once we get in there, and if we're saving money, we find other relationships that want to reimburse us for that care, great. But if we were waitlisting people, and we were spending so much time in intake and referral just over that financial piece, and we'll want to get in there and get the services going and figure out ways that we can pay for that, so that we can get back to the business of the social model, taking care of the health and wellness, and reducing costs for everybody, not just focusing on the individuals. So that definitely is a huge engagement process for sure.
So, yeah, it is a loaded question, but I mean, it's a very good push. Because what I've learned, and I've heard this from a kind of a famous patient who said, a patient or your client is really interested in 3 things. Doc, social worker, can I trust you? Do you care about me? Why are you here? Second, do you care about me as an individual? Are you just sitting there listening to me? Am I just another 10, 15-minute visit? Or do you really care about me? Do you know anything about me? Do you know who I am? Are you having a relationship? And then the third is, do you know what you're doing? Do you have the expertise? Those are really the 3 things. Now, what we find, at least from what I read, patients still have a trust relationship with their physicians. But there's very little that that physician does with that trust relationship unless they have a built-in infrastructure and team that can go in. So when the patient, and we're dealing with a population that has huge trust issues, okay? Minority population many times has huge trust issues, not only of the justice system, but the health system, because they haven't always been treated well. They don't understand it. So when they let you in your home, those are the 3 things they're asking. But in order to develop that trust, I think Janet Jackson said, what have you done for me lately? And when you get into their home and learn about them, we're learning not only what we think our goals are, but their goals. What we like to do is focus on their goals, simply because we have relationships not only with the physician, but with the hospital, with the health system who is controlling their benefits. We can get on the phone and say, what we learn is this person needs a wheelchair, needs a new walker, they need a shower chair, they need this referral, and then the team advocates and streamlines that. And they come back and say, I've been trying to get this for 2 months. You got it for me yesterday. That's trust. That's why they call Multicultural and not me.
And John, you have an interesting, kind of a different way of needing to engage people.
Well, I was going to say, for us, you know, we're obviously changing how we're going to be handling our calls, and we've done it in our health navigation and veterans is once you tell our navigators that are upstairs that are taking these calls that it's just not a referral that this person's going away. It's actually now going to be a case record. It's going to be a shared case that we're now giving to a community-based organization. There's a lot of culture change that's going to happen in our organization. And it's probably going to happen with all of you, with your case managers. You know, it's a little different when you meet. I mean, you guys are doing that next generation where I think we all aspire to be over the next 5 to 10 years, because that level of coordination, which we know works, how do you get there from where we are? I mean, I remember being at an event a few years ago where we were training case managers. They didn't even know how to use our website to look up the local resource. They were still using, you know, something more on paper. You know, and they're looking through it going, oh, here's the place I refer. And so we thought, okay, how do we make sure that our site is as easy to use so case managers are using that technology? Now we're going to say, you're going to get a shared case record, or we're going to ask you to look up in the CIE when you pull up a client, so that you're not only dealing with that client came in for, but you're now a community representative of what other things that that client is going to need from other organizations, and being a participant in it. That's going to create a huge culture change. It's going to create a change in our navigators and how we answer a call and how we refer and how we handle that client over and over a period of time. It's going to affect the service sector, which is a big reason why when we moved in this facility, we created downstairs is the connection center. Our hope is that that's going to be a place where we can come together as a community and say, as the tool continues to get developed, is it working? What needs to change? You know, all of the community-based organizations are users to say, this works for me or it doesn't. Hey, John, it needs to be that type of a dialogue that we have. So I feel like, you know, we can get stuck on privacy and security and interoperability and systems and all that, but if we don't have the trust and relationships with people saying, hey, if we actually want to do this together, you know, we might as well just pack up our toys and go home, because it's not going to happen.
Any other
I'm
questions?
not packing my toys.
So I have a question for Dr. Hood. So you talk a lot about patient-centered care. Are you working at all with the medical schools, at least locally, to try and promote or advocate for multicultural trainings, especially for MDs and RNs and all of that, or at least maybe working to create some pipelines for some underrepresented youth to get into the medical field?
Excellent question. That is my passion. I am on the, I was, when I first graduated from UCSD Medical School, I still in the volunteer clinical faculty training, and many students rotate through my office. When I started this program, so I give lectures at medical school at one time. And as a result of that, recruited quite a few of the pre-med and med students to actually volunteer in our program. UCSD has a unique program called PRIME. Don't ask me what PRIME stands for, but it's as they admit about 100 students, about 20 of them are admitted to what they call the PRIME program, where they will graduate not only with an MD degree, but a specialty in health equity and or public health. Many of them rotate through my office. Many of them have volunteered in the Patient Health Improvement Initiative. As a matter of fact, the volunteer program that we have, we call it our secret sauce. When we compare what we were doing here in San Diego to the other sites across the country, there is a regression to the mean. So in essence, we're dealing with sick patients who don't know how to navigate the system. They've had a lifelong history of bad behavior, and our intervention was about 6 months. And then we withdraw that intervention. There's a certain percent that just regress back to where they were. Our regression to the mean has been less, and I can't prove this, but we think it has to do with our volunteer program, who includes pre-med, med students, faith-based organizations volunteer. They're calling these patients every week. So even after we withdraw, many times they'll come back with what we call actionable items that will get back to us. As a matter of fact, when we meet on a weekly basis, our volunteer coordinators actually incorporated in that, bringing this information to the team to let us know that we need to re-engage. The students like it so much that a couple of them are now doing research with the foundation on social determinants of health.
So once you have real data that shows cost savings for preventative and intervention programs, how do you convince the national billion-dollar healthcare agencies who want to pay for surgery instead of paying for physical therapy, because the doctors get paid for the surgery and not for physical therapy? How do you convince them that it's better for the patient and not for financial benefits of their,
And
you
that
know,
is
stockbrokers.
$10 million question, right?
Oh, it's $10 billion question. But, you know, if you're not looking at outcomes for healthcare providers, then what's the end game for them? Just
So again, another one of my passions.
Besides being the best primary care doctor.
Yeah.
Lots of passions.
But that's a critical issue.
Yeah.
And I don't know how to change the national scope, but my focus has been on the docs that I deal with. And I'm proud to say slowly but surely they're getting it. Slowly but surely they're getting it. They're learning that the individual doc did not exist in himself. He needs to collaborate and have a team, especially for difficult patients. But one of the things that I think is waking them up is this whole quality issue. I don't know if you've heard of the CMS STAR program and the pay for performance. So as providers now, CMS has said to the health system, in order to continue to get contracts with CMS, we need to monitor your quality. And the top quality is 5-star. And they set parameters to say in 2 years, if you're not at 2 or 3 stars, we won't contract. In 4 years, if you're not at 4 stars, by this year you have to be between 4 and 5. What most folks don't realize is sometimes in the measuring quality measures, how well are your diabetics controlled, how well is the blood pressure control, your mammograms, your screening. And in a fragmented system, especially for independent docs and even clinics, maintaining that quality, documenting that quality is difficult. And sometimes it's just a few patients that will take you from a 4 or 5 star down to a 1 or 2 star. So the IPA is seeing their stars go from 4 years ago, 1.5 to now 4. So the individual docs are now seeing that by working with programs like this, that they said, well, I can't force this patient to get a mammogram.
Yeah.
I can't force this patient to come in to see me to get the A1C check. I give it to our virtual patient-centered medical home team. You know, we work with them, we get them into your office, we get the assist you getting the mammograms done. So I think that incentive now for the provider to want to engage these patients in ways that they can. We actually use mobile docs that should go to the home individually. So I think slowly but surely, quality measures and whatnot are going to force docs to become more sensitive to what we're talking about.
how does that translate to being reimbursed as an independent physician if they're not, you know, prescribing a procedure or a medication?
Because it translates into being reimbursed if you're at our docs, the docs at 4 and 5 stars will get an extra bonus.
Okay.
The docs at 1 star will not. There are certain quality measures. Certain docs, if you don't meet those quality measures, you won't get the bonus.
Okay.
I think to add to that, for us, because we're not as clinically focused, but we have had UC Berkeley School of Aging, rather. We did have an 18-month study, and we do have very evidence-based documents that we reduce falls 88%. You know, so we do have all that data. We put it out there all the time. And I do think that it is a huge windmill tipping project to work it backwards, because for us, we're working towards physicians groups who then have access to managed health care, who then have access to CMS, and going that way, because trying to do it the other way around, I think, is impossible. Quite honestly, I think we have a duty, no matter how hard it is, to continue trying to create the evidence and show it to them. Also paying attention to what they're being reimbursed for, what they're being rewarded for, what they're being penalized for. Going back, we have a program. And I do think San Diego's lucky in that the managed healthcare agencies and cities talk to each other. We all talk to each other, work together, have relationships, even though they can't quite steer the ship the way we wanted to go, as quickly as we wanted to go. I think they're all talking and listening, and they're hopeful. So I just think we have a duty to continue taking that evidence up the consumption chain, through the physician groups, through the clinics, up to insurance, and all the way up to eventually affect that change. And it does mean creating pilots, measuring, showing the documentation, and over time, hoping that there'll be a reimbursement model that will reimburse us for these things because we've been able to document the cost of these.
Yeah, and there's pilots like those all over the country. So if they're, it's kind of like that. Yeah.
I just want to kind of reflect back just some really important things that you've said and all of you've said. And I think one of the important parts is the continuum of needs that families have. And Dr. Hood, you talked about for a certain group of patients, we need to approach it from a team perspective. I think you have the evidence and the information to say, what does that team look like? What does it cost? And then we've got to start thinking about funding as it relates to the patient function. As a pediatrician, I always think of family function, but we need to think about it as the function. And so to get to the payer model, it really is saying in the continuum of need, this group of individuals needs team care where the physician is a part of the team. And then you can actually start saying, and I think you have a lot of the elements in the work that you've done to maybe bring in an economist or somebody who thinks a little differently than we do to further look at the model that you've already created. And I think you've gone a very long way in saying how to handle what group of patients that need this extra work and the social determinants of health. I mean, I think you've got all of the elements here, and it's really just some tying things together. To get to the payments, we've really got to be able to demonstrate so clearly the cost.
So real briefly, and then I'm going to ask Dr. Nora Fain. Maybe she can talk about this. I think Molina Health Plan is one of the progressive health plans that we've dealt with. That health plans usually have their own infrastructure. They're not used to dealing with community-based entities. Molina is, we've been working with them for several years, and I think it's safe to say soon we'll have a contract in place to kind of work with our group. And so I think it would be good to get her perspective. But I've just been appointed to call it the primary care alternative payment model. It's a group of us that was selected nationally. And I just was appointed to it. And basically it's to discuss how can we develop these various payment models. And I was appointed to it mainly because of the experience in the patient health improvement of Multicultural Health Foundation. So I think we have developed something, but it's really kind of convincing, like health plans, CMS, and the state. How do you reimburse this? Because that's now where most not-for-profits, this is a very uncomfortable area to talk about profit and whatnot. And most folks don't get what I'm trying to say. But really what I'm saying is, how do we get money from the Molinas and all the health plans down to the community level where they can do the intervention there, where I think they do it better than the Molinas and whatnot would do for a certain population. So we haven't figured that out yet, but that's where we're going.
Well, one of the things that Molina Healthcare actually discovered in working with the Patient Health Improvement Initiative and Montrula, Alicia, and her team is that we do have a large infrastructure within the plan for care coordination and care management, but there is a subset of our population that we know we are not going to be effective with. And by recognizing that and understanding that, then we can work with the PHII in saying, how can we collaborate? How can we support your efforts in order to be able to better reach this population and to achieve the health and wellness outcomes that we all want for our members, for the patients, for the physicians. And what we found is that working together, working with the PHII team, really having open and continuous dialogue, that we have some really significant successes. It is a matter of everyone bringing to the table what they do best. So from a plan perspective, we have the benefit. We can provide the walker. We can provide the referral. We can move the prior authorization along, etc. And that's where Montreal and her team come in saying, we really need to do this. We've been in the home. We know what the needs are. We need to make sure that the participant has these services. And so that collaboration makes a difference. I'll also say that we know that we need to, and we are, I really feel very close to a contract with CenterMed and Multicultural Health Foundation, but also to get to that level where you have that level of integration and collaboration, there needs to be other investments that are made. And so Molina Healthcare has invested in 211 CIE, San Diego Health Connect, etc., because the infrastructure has to be built. Once the infrastructure is built and we're able to actually demonstrate and to track those costs and those savings, etc., and to be able to have those systems in place to achieve the level of integration that the panelists are talking about. And I love the collaboration and integration because it has to be integrated. We have to get past the silos, etc., and know that the teams have to work together, recognizing each other's strengths and playing to those strengths, investing in that in a way that's going to bring that to scale for our communities is the only way that we're going to be successful. So, you know, if I've had the privilege of working with many people in this room and certainly on the panel and seeing the great work, and I think the Molina Healthcare members have benefited from that, and there's just a lot of incredible work that's going to happen in the future.
So I guess I just want to add one little piece is who else besides the healthcare system benefits from the work? And I think that's where like bringing in an economist helps to think about, because the work that you're doing really transcends the medical system and even transcends wellness. You're really looking at individual function. So again, I think it's great that we're building this, and I think to keep that going and to keep the funding going, it really is pushing people outside of the medical system to say, what's your role in paying? I mean, on the elder side, the work that you do, you're saving a lot of dollars for a lot of individuals. As a society, we benefit from all of your work. The question then becomes is, who in the society can we say has a stake in paying for those cost savings? Because the cost savings you're talking about are one piece, but the larger part is the benefit of the wellness of the individuals that we all, from a moral perspective, would like. You're doing both. And I think we just need to push beyond the healthcare system to say, who else needs to pay? Because the work is incredible. It's incredible, and it's a groundswell.
And you bring up a great point because, I mean, traditionally speaking, the prosperity of a nation is directly related to the overall health of our population and our communities.
Yeah.
So it votes, and we spend more than 50% of all healthcare spending in the world.
Yeah.
We are by far, of course, the largest amount, but we don't even rate in the top 30 health metrics.
Absolutely.
Compared to industrialized nations everywhere. So it is an inefficient system that we're spending that much money and we're still not performing health-wise as a nation. So there's so much money being left on the table.
Yeah.
And there's so much, 35% of every dollar in healthcare is hospitalization, 35% is pharmaceutical. It takes $4 million to $11 million just to bring a new drug to market. And that cost is all being passed on. So it's very inefficient. And we do know that we're going out there and trying to pilot these programs. We know they're effective, but to your point, who is getting the benefit of the work we're doing is willing to pay pennies on the dollar to do that. And there has to be motivation all the way up the food chain. And for some agencies and government entities, they're not interested in that. And so you're dealing with the whole psychology, and again, the culture shift, how to get to the right people and say, why would you want to be able to increase the health and wellness of the community for pennies on the dollar using this whole new model that brings all these different parts together and does that. Who's going to benefit, and are they willing? Some people, some agencies like their largesse. They fight on that. They like their employment numbers. They like their budgets. It's a whole different undertaking to go after them and tip those windmills. And that being said, I think I might speak for, it doesn't stop us from trying, because we believe so strongly in what we're doing, and we know we're making an impact. We see it every day out in the field, every hour. So we're not going to give up our responsibility to keep doing that. But you're right. I mean, all the points you bring are absolutely spot on.
So I totally agree. We are having a medical economist look at this.
Yeah.
But it's really just a matter of changing the culture.
Yep.
And that's going to be very, very slow, very, very difficult work. I'm convinced that until you develop a local model that shows it can work on a small scale,
Yeah. Oh, yeah.
then we can go up and say, here's what we can do. And that's what I like about what's happening in San Diego. I've got a lot of scars that you can't see.
After that meeting, I'll show you.
From trying to break down silos.
Yep.
Barriers. Sometimes I say things I shouldn't say. But if you want to know how to change the system, I simply say follow the money. And how do we get the money from up here to down? And either you legislate it or you show the folks who are controlling the money there's a value by diverting in this direction.
Are there
I'm not following.
That I know. So I think that when I keep looking over at the questions, I think we've touched on most of them. We didn't do a whole lot of in-depth around the ACEs study that recently came out. Are there other areas or other ways that you might want to go deeper into some of these areas, or something else that has come up for you? Other questions?
I just want to say that it's really wonderful that this forum has held.
Thank you.
Because, it's a start. And for everybody to come together, so this kind of breaks the ice so that we can all feel more comfortable working with each other. So I think this forum is really, really very needed and very helpful. Thank you for doing that.
Well, thank you. Thank you. It's really part of what we're trying to do under our iEngageU. And it's not just about us engaging you guys, but it's about you guys engaging each other as well and learning from the community. And, these are some of the things that we funded. And that's how we kind of get the ideas like, hey, we think others might want to know about this. So we really want to kind of promote that. But we're also interested in learning what else is happening out in the community, because I think all of that really informs everybody in the community. And hopefully we begin to see these changes begin to happen, right? Absolutely. Would y'all like to make any final closing remarks?
I went first last time.
Shameless plug. With still the awareness that 201 has, we're still only 1 in 3 San Diegans know about the service. Yeah. So we do have posters and wallet cards, and we were thinking if we could just have all of you canvass whether it's your waiting rooms or your break rooms, because the hope is that if more people know about us, we're going to receive those interactions, and we're going to be able to build the scale of what we're trying to do even further. So if there's any way that you can help us with that, or just we'd love to co-brand at different events, so that if you have this is another one of those. How many times do you have to staff a booth at an event? We're staffing a booth. We try to put together our community calendar every month of where we're going to be and what other events are at. If you look and see that we're going to be at the same thing together, maybe there's ways that we can work together as well. Because again, hopefully people see us working together and working on common projects together as well.
So, the Multicultural Health Foundation and IPA's goal is to put us out of business. I'm working very hard that people do not need to come to me as a physician. And I said that 30 years ago, realizing I'd be around a long time. But wellness costs money. And there's very little, maybe 1 or 2% of the healthcare dollar goes towards wellness. Yeah. And so we really need to figure out a way how to divert, not ask for new money, but divert the money that's already in the system to build a wellness infrastructure. Because until that happens, not much of the
I will just say that I think collaboration and integration is worth all of the sweat, equity, and pain and discomfort that it entails. I am passionate about that. There's nothing that feels better than bringing all these diverse people to the table and see a plan start to take shape and be successful. And because we were focusing a lot on collaboration today, I did want to just mention that the Center for Nonprofit Excellence has some great resources out there for collaboration, including checklists and all that. Also, grantspace.org has a collaboration hub that's really interesting. And of course, Chronicle Philanthropy and bridgeband.org, but they're all really great resources for taking a look at what does it take to collaborate, what should you be looking at, what is the process, the checklist that you should be thinking about before you go into that. So I just want to make those recommendations.
And I just wanted to say that I find it really interesting that at one level, we're talking about this whole systems change that needs to happen in order to really get to a whole person care coordination system that's happening in our community. And I'm excited about the conversations that are happening and seeing this really starting to develop in San Diego County. And at the same time, I'm struck by the fact that so many of our conversations are coming to how it's really one-on-one touch, one-on-one care, one-on-one relationships that we're trying to build in order to get to a place where we have whole person care coordination. So it's this big macro picture, but it's also what really is making the difference is those one-on-one conversations and relationships that all of y'all are building with the people that you're working with. So we really thank you so much for what you're doing in our community and the work that you're providing and your dedication and your stick-to-itness, because we realize it's going to take a while, and hopefully we can be behind you helping to support that effort. So thank you all very much for being here. Thank you for all that you do. Thank you, guys.
I keep forgetting one last thing. I'm so sorry. I want to thank staff in the back for putting this all together. Michelle, okay, all of them. And also, I have two board members, committee members here. Dwight Smith is on our board of directors. Actually, I have three. Dr. Hood is on our board as well, and Dr. Norfay is on our program committee. So thank you all for
See you.